Hello everyone, welcome to this audio podcast. This audio podcast today as part of this audio podcast as part of the conglomerate. This audio podcast as part of a lobostic shystorm, and this audio podcast as part of a storm and battle and chronicle, and this audio podcast as part of the Ztormish series, the Ztormish series or edition, and this audio podcast as part of a storm lobostics production. In this audio podcast today, I look at a condition known in the literature and referred to as IgA nephropathy or IgAN. In this audio podcast, the overview will be an intro to IgA nephropathy. I look at some epidemiology. I look at some pathogenesis. I look at some symptomology. I look at clinical manifestations, and look at biomarkers. I look at disease aspects around disease progression, and then pharmacotherapy strategies. So to begin with, IgA nephropathy is a condition that's that in amongst retrospective literature is referred to as Buerger's disease. Recipients can present with a range of signs and symptoms from asymptomatic microscopic hematuria to macroscopic hematuria and or other sort of renal or kidney abnormalities. IgAN is perhaps one of the most common forms of glomerular disease and glomerulonephritis, sort of globally, and associated with a poor prognosis and resulting in ESRD or ESKD. IgA deposits or deposits are often associated with systemic conditions such as Henoch-Schönlein purpura or HSP. Susceptibility to IgAN and risk of disease progression are influenced by confluence of genetic and environmental factors. Now looking at in around the epidemiology, so the prevalence of IgAN varies geographically, and estimated of disease burden varies according to biopsy data or KRT, kidney replacement therapy, or renal replacement therapy data registries. It is common cause of CKD with an overall incidence of in around 2.5 per 100,000 individuals. Epidemiological investigations have informed that incidence is increased in individuals of Pacific Asian origin, but at the same time, in more recent literature, the epidemiological investigations have also informed that IgAN affects across varying ethnicities. In up to 50% of IgAN recipients the condition progresses to ESRD or ESKD within 20 to 25 years, if not earlier. IgAN more frequently occurs in males than in females, and usually affects affects 16 to 35-year-olds, which account for approximately 80% of total recipients. In around the pathogenesis, excuse me, in around the pathogenesis, the disease occurs when immunoglobulin A IgA deposits in the kidneys lead to the development of local inflammation and renal injury and considered IgAN is also considered as a sort of an autoimmune condition or disease, or with a multi-hit hypothesis, sort of hypotheses. First hit the production of galactose deficient IgA1, and where it plays an important role in the formation of immune complexes. The second hit is where there was a production of IgG autoantibodies, which target the O glycans in the hinge region, and also leading to the formation of immune complexes. These complexes induce sort of local inflammatory responses, and they are deposited in the kidneys. This leads to the activation and mesangial cell damage. Also, antibodies involved in the IgAN and pathogenesis include GD, IgA1, anti-glycan autoantibody, and C3. In around sort of the symptomologies, there can be pain in the abdomen, acute renal failure, or acute kidney injury. There can be blood or hematuria in amongst the urine, and there can be anomalies in around ABP, arterial blood pressure. In around the clinical manifestations, the range of clinical manifestations of IgAN is broad, from asymptomatic to microscopic hematuria to rapidly progressive GN or glomerulonephritis. The common phenotypes, the two most common clinical presentations are asymptomatic hematuria and progressive kidney disease or renal disease. Asymptomatic hematuria with minimal symptomologies of particular parameters may be detected through screening or diagnostic investigations. Isolated microscopic hematuria with particular minimal parameters, with particular biochemistry parameters, with minimal biochemistry parameters, particular biochemistry parameters is regarded, or have been regarded as useful for favorable prognoses. Renal survive or prognoses ranges according to biopsy timing. Factors associated with poor prognosis include abnormal or anomalies in around ABP and a decrease in EGFR at diagnosis. At the same time, race and ethnicity has been an important determinant of outcome. Pharyngetic microscopic hematuria is a classic clinical syndrome associated with the first presentation of IgAN. Persistent sort of biochemistry parameters or parameters through laboratory analysis can tend to be associated with progressive IgAN. And now looking at a little bit on biomarkers. So renal biopsy is the gold standard for diagnosis and assessment of disease or disease activity and prognosis. Biomarkers IgA1 is increased in the blood and urine of recipients with IgAN. IgA1 in the serum of recipients with IgA have been found within immune complexes bound to IgG or IgA1 antibodies. Serum levels of IgA1 and specific IgG autoantibodies are correlated with disease severity. Increased serum IgA1 levels are associated with in around a greater risk of deterioration of renal function in amongst IgAN recipients. A combination of high serum IgA1 levels and levels of advanced oxidation products is and has been correlated with a more rapid decline in EGFR. Now looking at slowing renal damage. So corticosteroids and immunosuppressive pharmacotherapeutics tend to have been evidenced to calm the immune system and sort of preclude it from attacking glomeruli. Pharmacotherapeutics such as angiotensin converting enzyme inhibitors and angiotensin receptor blockers have been used have been evidenced and to help help those diagnosed with IgAN and are used to control ABP abnormalities or control ABP anomalies. In addition, as in around sort of in around pharmacotherapeutics and sort of additional sort of strategies, conservative therapy, and one of the bases is to reduce the rate of renal insufficiency, and in around the use of corticosteroids. The aim is to reduce negatively implicated by biochemical or biochemistry parameters in IgAN, and investigations have suggested that the exposure to the exposure or the use of corticosteroids in IgAN recipients for in around 6 month duration may have what has been referred in the literature as a legacy effect, with sustained reduction in the risk of progressive renal dysfunction. Monoclonal pharmacotherapeutics such as immunosuppression such as mycophenolate. Data regarding the efficacy of mycophenolate are mixed. And current clinical guidelines have recommended against recommended sort of the and against the use of mycophenolate in IgAN. Another pharmacotherapeutic, a monoclonal antibody, in several investigations, rituximab has non-effects non-effects on particular biochemistry parameters in IgAN or recipients, in IgAN recipients, and combination therapy is generally reserved for recipients with progressive IgAN. In treatment on IgAN recipients, there have been data to inform the renal prognosis after 2 years after 2 years or post 2 years of combination pharmacotherapeutics can be helpful. That draws this audio podcast to a close. This audio podcast as part of the conglomerate. This audio podcast is part of a Labostics Shystorm. This audio podcast is part of a Storm and Battle Chronicle. This audio podcast as part of the Ztormish Series or edition, and this audio podcast as part of a Storm Labostics production.